you know, is always very, very difficult to make predictions. We have several drugs that are in phase 2. There are some drugs that have been discontinued. We have a big problem in the case of HBV cure. We have drugs that works well. They do not solve the problem, but they are very, very safe. So we cannot accept risks with this disease. It's very, very difficult to make prediction of time. The way for regulatory is very, very long. I would say that if I say that in 3 years or in 2 years, we may have one drug approved or near approval, I probably not so mistaken, but I will not bet my head on that. That's clear.
Okay, so I think I have another question for Capucine. I think she's on. Can you unmute your microphone, please?
Yes, Manuel.
So I would like to know, do you have any plans to include research centers in Africa? Because as you can see, there are many drugs that are in the process of phase 2 trials and or even in preclinical trials. So what are your plans to include African centers in research? As you know, Africa has a high prevalence of hepatitis B, and very few clinical trials include Africa for hepatitis B, whether for adults or for children or for any other population. So I think maybe ICE's role may be to network a little bit more and bring in on board some of those research centers in Africa to include within clinical trials. Do you have any plans?
Thank you, Manel. Yeah, go ahead, Massimo. You want to answer?
If you ask me if I have plans, I am not a pharma industry. I'm not an entity that starts trials. So I cannot have plans. I completely agree with you. We must continue to pressure to enlarge the basis for having more and more centers coming in the clinical trials. You know very well, it's very clear that in the first phases of the development of drug, the pharma companies are very, very keen to have fast recruitment and relatively little number of centers. One of the most active centers is in New Zealand because they are very, very organized to run very, very fast with all the required ethical committees and so on, but very fast this kind of trials. As a French or as an ex-Italian, now French, I get, let's say, sometimes I get nervous because they are much faster and we are not included. So I think that we have to think of it, we have to pressure, and this is the role for ICE. But we will not be able probably to change this, at least for the very early phases, because this is very complicated, as you know. Let me just say one last thing. What I think we can do as ICE and as clinician working in Africa is to push not only the industry, but also entities like NRS that has a long tradition to come also with trials in the south of the world, and in particular in Africa for HIV. We can use that kind of structure, because as the structure to sponsor studies, so we can use that at a certain point to push for what you are looking for the pediatrics, for Africa, and I completely agree. But is a complicated process, and we will not solve today. I mean, we can say whatever. Yeah. If I say we will do it, I will just be sending hair. But I think we have to push for it all together. And ICE has a role on that, and there's a willingness as well.
Yeah, I think
I agree.
Yeah,
I agree with you, Massimo. I think ICE HBV can influence industry and also research agencies to be doing that. So that's something we can take on as an advocacy. And I think there's also a few other questions. I was looking in the same topic on how can African get involved in cure trials. I think we already answered that, but maybe there's something we can add.
Yeah, no, not really on that, but I was looking at the same time. I'm stealing the job of Manal. I was looking at the same time to the questions that are coming, and and there are two questions that I think we probably should try to answer. One question is, are there any report of functional cure by HBV, of HBV by loss of S antigen in patients on nucleotide analogs? Yes, obviously, if you treat very, very long time, you may have some loss of HBS in specific subcategory of patients. We do not know all the determinants. If you already start with a very, very low quantitative HBS, you have more chance to go for it, but the chance is very, very little. Is years and years, and is less than 0.5% per year, and doesn't start before 3-4 years in most of the patients. So there is really a need for something better than the nukes all alone. In the second point is, what would be the advantage of a complete HBV cure versus virus suppression? There are two advantages. The easy one to say, one, it will be a finite cure, so you have not to take the pill for forever. Few patients will be able to have functional cure just by stopping nuke after 3-4 years, but they are a minority, and nuke alone is not efficient. The advantage is that you will be able to stop, and in some context, the people in the US, like I think, imagine also in Africa, where it's difficult to get the virus suppression, the tenofovir, to say that you have to buy it for 3 years with something else, or for 1 year with something else, or for 6 months with something else, is much easier to sell than to say you have to take this pill forever, and eventually you are far from hospitals, so you have no controls. It's not easy. The second point is that for 5 years, you still have a big risk of cancer. 5 to 7 years of nuke. So this is the other point. If we get more functional cure, we lower exponentially the risk of liver cancer. This is a major point.
And I would add to that also it may well be possible. I would also limit stigma. That a cure instead of treatment would really benefit the stigma and self-stigma that people living with hepatitis B can have.
Yeah, I was being a little bit too much doctor, and I was saying in some context, but obviously not only in Africa, but let's think of the Asiatic communities. They have the same big problem with stigma for hepatitis B, and so is a problem that is larger than Africa. Today we are in Africa with our art, even if I'm in Europe now, but is a big problem. Yes.
Well, actually, the stigma is even much higher in children than in adults. They can't go to schools, they can't play sports, people avoid them completely. And the problem with children is that you cannot treat them unless they have elevated transaminases. They are the so-called immune tolerant. They do not fit exactly into the EASL's classification. They did not consider children when they classified. They've done this new classification, EASL, and I want your opinion about this. Because most of those children do not fit in this classification. And I'm seeing tens and tens of children with very, very high viral loads, extremely high viral loads, and normal transaminases, and their parents are scared that they might infect others, and they don't know what to do. And we have no solutions for them.
Actually, we discussed that in a similar panel at the end of a session at the EASL, the virtual EASL. I was stimulated to talk about that by Patrick Kennedy, and I completely agree with you. The paradigm of who should be treated in the different phases of the disease as defined by EASL, actually the immunotolerant are now the chronic infection positive, but it's the same. The groups are just change the name to be a little bit more precise and less evocative of things that are not completely true, because there is no real immunotolerance in the so-called immunotolerant. But finally, for hepatitis B, there is not only the clock of fibrosis, there is also the clock of the virus. We should start to treat before. The problem is that we say that we don't treat before the transaminases because we know that the usual treatments, the one that we have, particularly interferon in the old days, they didn't work. So we didn't treat because they didn't work, and then we still not treat because we have nothing really working. If we have a functional cure with a different combination of drugs, immunotolerant will become
Yes.
a target. I don't know whether the children will be the first target, because obviously, as you know, there are more regulatory problems around children than every trials for children. Sometimes is also ostracized by the company. They first want to have the proof of efficacy and of advantage, clinical advantage in adults. But I completely agree with you. If we go for better drugs, the time for children will come before, and it will not, I hope very much, will not be only the immunoactive. I mean, I'm sure that we will be able to target the young people without so much disease and without inflammation, and that is good, because as early you treat, better results we will get. This is Antonio Bertoletti that always teach us from his immunological perspective.
Yeah. So there is a question here about any update on treatment of hepatitis B in early pregnancy.
We are good with what we have, I would say, and I mean, everything goes well following the rules we have now. So treat earlier in pregnancy can be done. Is not the guidelines. I don't see it is a problem of access to the different treatments. Is a problem of reaching out to all the people that need it. But if you are in a system that works, I know that in Africa is much more, there was a session yesterday discussing a lot about that, it's much more complicated. But if we follow what is commonly said, the risk for the baby to get the infection is very, very low. You need to vaccinate in 24 hours. You need to lower the viral load in the mother in the last trimester, but also earlier. Always remember that if there are the criteria to treat, because there are the criteria to treat the hepatitis, the mother, you started the therapy before. Even if you discover the disease just because of the pregnancy, because this is what happens. You did, and after you have to apply your knowledge as a hepatologist and decide, I treat because I want to prevent transmission, or I treat because I need to treat the mother. And you can modulate the way to go for it. And we have a drug that is very good, because tenofovir, there are more and more data saying that it's safe. So we have what we need. We have to be put into the situation that we can do it. We need access to the drug. We need cheap access to the drug. We need access to the vaccine. We need access to the immunoglobulin when it is relevant.
No, immunoglobulin is not going to be available.
I know that this is
very.
This is why
it's not available.
This is why I put as the last point, because I clearly understand.
The last point, yeah.
Clearly understand.
This is
but also without immunoglobulin, if the vaccination is done quite timely, and the results are very good, then if you do the prophylaxis at the same time, what you gain with immunoglobulin is not so much. So I think that we are not bad for the pregnancy if we do what we need to do.
So I think Professor Fall joined.
Okay.
Sorry, Manon.
That's great. Where?
Fatou, vous nous entendez? Yeah, I'm not sure she'll be able to participate. So maybe go ahead. Sorry.
Yeah. On parle français là, Capucine? No. We have to stick to the.
So earlier there was a question about TAF. So, and there were questions about is it better for patients in Africa to roll out TAF instead of the tenofovir with less side effects, possibly? Maybe we had a comment from Philippe Isebrook from WHO said, but there are some data that it increases the weight in adults. So what do you think about TAF?
So I live now and I work in a country that is considered a rich country, France, in which the authorities didn't approve TAF because there is not enough new advantages compared to tenofovir. So I'm biased. I think that there are situations in which we would need TAF and it would be very, very good to have TAF. Whether TAF is the solution in Africa, it will depend mainly on availability and price. I think that there is a slight advantage in terms of side effects. And I would say that in some populations, we experience a more difficult management with tenofovir because the people start with, let's say, not a renal insufficiency, but values that are less good, and they may just slowly go to level of danger, or I mean of the tension. In my clinical practice, I have a lot of patients from sub-Saharan Africa in which with tenofovir, I have a little bit more problem with the kidney function than I was used to have when my patients were less varied, let's say, in Rome, when I was working in Italy. So I think that there is value for TAF, but is all in the hands of who produce it, who will produce it, who will sell it, who will buy it. So it's a question of price. I don't think that today we can say we have to go for TAF today. It would be already very, very good if we had tenofovir for every patient needing it at a sustainable price, given by the governments, given by the Global Fund or whatever. But now I'm stepping out from my scientific role today.
Okay. So Capucine, can you explain to us the role of ICE maybe in Africa and trying to improve advocacy towards treatment of HBV infected patients?
Sure. So we do a few things, and we have currently one African representative on our governing board, and soon, hopefully, two. One thing that we have done recently, for instance, was to work with many partners around the world to have a session at the Global Fund Replenishment Conference. And Massimo was speaking there in Lyon earlier last year. And this session really aimed to advocate for the integration of hepatitis B, hepatitis C too, actually, in the Global Fund portfolio to really better integrate what they're doing for HIV, tuberculosis, and malaria with the hepatitis response, and to open their programs to further hepatitis work. That's one of the things we're doing. And we work with research agencies, with doctors, with researchers, with communities, with pharma, and with all the stakeholders that really can push that agenda forward. That's one of the things we do. Massimo, I see you want to say something.
Yeah, we also, this is not, it is not really mature yet, but we also have a working group around the issues of point of care. And I think that very innovative point of care strategies will be very, very important to reach out better and keep the price low when we think of many situations in Africa.
We're actually thinking of reviewing from a resource limited setting all the HBV management practices. So we're starting that international working groups, which will have representative from Africa, from Asia Pacific and other continents. And we'll look into what are the recommendations currently, WHO wants, and try to improve them.
Just to say something a little bit fancy, obviously COVID is a kind of damnation for everybody, and some continents already paid the price, others are still paying the big price for the pandemic. But there was a huge amount of brain and money put into the research for COVID, and I just learned that there are some technologies that are being developed for COVID, but can be adapted for other viruses. And in particular, I was talking with people about that for hepatitis B. That might be really, really interesting, and it's surprising what the mind of people can invent. So something that looks like a CD player and does the test, and is is nice, and would be very cheap and very very easy to implement. Obviously, it can work and not work, can be trustful, can be good for all the situation. I don't know, but there is movement. There are things, and ICE is doing something there. We are active, and we will continue to be.
Thank you very much. That was an excellent session. Thanks to ICE, and we look forward to continuing our collaboration with COLDA. So thanks for this great session.